Okay, if everyone could find your seat, please. So I got to say, I'm really appreciative of all of you hanging around. I know it's been a long day, and I hope it's been a productive day. I guess I'll be like a lead singer of a band and say thank you, Ypsilanti. You've been great, but you really have. You've been amazing. Thank you for all the engagement. I'm really excited about this last panel, and I want to give particular thanks to Dr. Khaldun for agreeing to moderate this last panel. When I first reached out to her, she was the Detroit City Health Commissioner. And then for those in Michigan, you know that she has just received a very well-deserved, incredible promotion to now lead healthcare in our state. And I'm really thankful that she could be here for our introductory panel, which was just a fantastic panel, and then be here to moderate this session, but also represent the important work happening in Detroit and the important work you've done there. So with that, I want to invite Dr. Khaldun and the rest of the panel up to the stage. Thanks.
Well, hello again, and thank you, Chad, for that wonderful reintroduction. I wasn't expecting that. It's been an honor to be invited here and to be a part of the conversation. So I have the pleasure of introducing our lovely panel, our last panel of the day. And first I have Dr. Luke Shaefer, who I've had the pleasure of working with for the past couple of years at the Detroit Health Department, and looking forward to continuing that partnership with the state. So Dr. Shaefer is the Director of Poverty Solutions and the Associate Professor in Gerald R. Ford School of Public Policy and School of Social Work at the University of Michigan. His research focuses on poverty and social welfare policy. I'm really excited to hear more about that today. He's been published in many top peer-reviewed academic journals, supported by many, many sources. He's testified across the country, including the U.S. Senate Finance Committee, and he actually recently authored a book with Catherine Eden called $2 a Day, Living on Almost Nothing in America. And it was actually named one of the 100 notable books of 2015 by the New York Times Book Review, which is a big deal. That book also won the Hillman Prize for Book Journalism. Dr. Shaefer received his Ph.D. and master's degree from the University of Chicago and his bachelor's from Oberlin College. Let's give him a round of applause. Next to him, I have Dr. Debra Furr-Holden. She is the interim director of the Division of Public Health at Michigan State University in the College of Human Medicine. Dr. Furr-Holden is the C.S. Mott Endowed Professor of Public Health and the interim director at the Michigan State University College of Human Medicine Division of Public Health. She's also the director of the National Institute on Minority Health and Health Disparities funded Flint Center for Health Equity Solutions, and she'll talk to us today about some of her work. Dr. Furr-Holden has been very engaged with the Flint community here in Michigan, and she's been exploring policy interventions to help address some of Flint's behavioral health challenges, including the opioid epidemic. Let's give her a round of applause as well. And then finally, all the way from Massachusetts and New York, I still think of you in New York, we have Dr. Mary Bassett. Dr. Bassett is the director of the Harvard FXB Center for Health and Human Rights and the François-Xavier Bagnoud, I probably butchered that, professor of the practice of health and human rights in the Department of Social and Behavioral Sciences at Harvard University. Dr. Bassett has over 30 years of experience in public health and has really dedicated her career to advancing health equity. She actually served as New York City's health commissioner from 2014 to 2018, a huge job. She's originally from New York City, but also lived in Zimbabwe for nearly 20 years, serving on faculty there, and also working on the African Health Initiative and the Child Wellbeing Program at the Doris Duke Charitable Foundation. She completed her medical residency at Harlem Hospital Center in Harlem, New York, and has a master's degree in public health from the University of Washington. So with that, I'd like to invite up Dr. Shaefer.
Good afternoon. I think I'm the only non-opioid expert on the slate today. I run Poverty Solutions. It's a university-wide initiative, and our mission is to partner with communities and policymakers and enhance work all across the university, across units, to find new ways to prevent and alleviate poverty. Opioids are not an issue that we sought out, but that sought us out. And we're really pleased to be partnering with Chad and Amy and many other colleagues as we understand the impact of this epidemic. Like with many social crises, the opioid epidemic is not something that impacts only poor communities. It can affect anyone, any family, any community. But at the same time, from my vantage point, it's important in particular to recognize that the impacts of this have been most devastating among low-income Americans in vulnerable communities. According to a CDC report issued in 2012, quote, Medicaid recipients and other low-income populations are at high risk for prescription drug overdose. According to a recent analysis by the Department of Health and Human Services in 2016, individuals with incomes under the poverty line were 2.1 percentage points more likely to have misused opioids in the past 12 months than those with incomes above 200%, and they were over twice as likely to have had an opioid use disorder. We see these impacts not just with individuals, but with communities as well. The same HHS research finds that from 2011 to 2014, on average, an increase of 1 percentage point in a county's poverty rate was associated with a 2.4% increase in the rate of opioid-related hospitalizations. While some high-poverty areas seem to be protected from this, the overall relationship is clear. Even more dramatically, during the same time period, an increase in 1 percentage point in a county's unemployment rate was associated with a 5.1 percentage point increase in the opioid-related hospitalization rate. So this is a structural challenge that's highly related to economic vulnerability, not just individual failings. One of the outcomes that I've spent a lot of time looking at recently is child homelessness. So in this, we're using Department of Education data where states are mandated to report by law the number of children who lack a fixed, regular, and adequate address. And these numbers have been rising since most districts have come in, from under 800,000 to about 1.3 million as of last count. And my own work with my student Mike Evangelist shows that looking only at a point in time, 1.3 million is a large number in and of itself. But in Michigan, when we look at kids and the administrative data from kindergarten to 12th grade, 1 in 10, over 10%, are experiencing this over the time of their education. So we find that this is related to structural factors, including the decline of the cash safety net. As cash assistance through temporary assistance for needy families has become less accessible, we see that 100 fewer TANF cases leads to 14 more homeless children. And Mike and I think, have the first of papers to find that increases in drug-related deaths and opioid prescription rates adjusted for populations are both associated with this increase in child homelessness. So I think this is compelling evidence that the epidemic we discuss here today is both a cause and a consequence of economic vulnerability and hardship. In my book, In $2 a Day, I started my career as a data nerd, a lover of spreadsheets and charts, and they still make me feel warm and cuddly inside. But in our book, $2 a Day, we wanted to go out and get to know families and try to find out families who were extremely low income. What were their lives like? What were the challenges they faced? And with the Department of Education definition of homelessness, there's a lot of debate around whether or not precarious double-ups when families are living with families and friends, if that should count. And this is just one of the cases. As we started to look in the data, we see that this is what housing insecurity looks like for many, many families. Unstable, not quite sure where the next place to sleep is going to be. This is Paul Heckwalder's family's front living room. They got a number of bunk beds that are stacked up together with 2 kids in each bunk. We've got a couch along the side, and then everybody's stuff sort of piled up in the corner. And I think something that is indicative of poverty in the United States, off the picture here is a flat screen TV, a very large flat screen TV that doesn't work. It's something that was pulled out of the trash, and Paul is convinced that he can fix it. Yet when you go into the room, it's quite striking and very easy, even for a poverty expert such as myself, to make assumptions. Recently, we partnered with the Close-Up Center, Center for State and Local Policy, and asked local officials what their biggest gaps in service were. And as a poverty guy, I was expecting to hear about affordable housing, workforce training, and transportation. And we did hear a lot about those things. Yet I was personally a little bit surprised to find that the most cited gap in services identified by local officials was substance abuse treatment facilities. Officials in nearly 75% of Michigan counties reported an unmet need for drug treatment programs in their jurisdiction. So as I go forward and I understand and the issues of opioids continue to bubble up, and from the vantage point I come from, I begin to wonder if we can understand that rather than separate or even competing needs, or at least separate and non-connected, these things, drug treatment, affordable housing, workforce training, have to go hand in hand. We got to know Ray McCormick is a part of our work in $2 a day, and this is a picture of Ray somewhere between the ages of 14 and 16, looking healthy, hanging out with her cat. You know, a picture that I think I'd be happy to be one of my own daughter. We fast forward about 10 years' time into her early 20s. This is Ray today with her own daughter, Aniva. She has numerous chronic health problems that are related to an unstable labor market that she's been trying to navigate, going in and out of employment with fluctuating work schedules, very little leeway, very little give, an inadequate safety net, a safety net where we've taken her in personally to try to get her cash assistance, and she's been rejected 3 times. A lack of affordable housing. Ray's options for housing are either to double up with her uncle George, who caused her to lose her last job, or an abusive ex-boyfriend. And finally, as mentioned in the previous panel, adverse childhood experiences and toxic stress, where in the families that we got to know, these experiences are ubiquitous. And so there is a lot of self-medication involved. In her case with Ray, she will go hungry for many days, but she's never goes the day without a cigarette. So how should we help Ray? Well, I can tell you from our experience that the place where we've been putting our money more than anywhere else is here. So this isn't Ray's medication table, but it's another one of the people who we got to know through the book, Mary's. And she has no money coming into the house, housing stability, all the things that affect Ray affect Mary as well. Yet she has 9 different medications going right now. And as my children like to point out, I'm not a doctor who helps people, apparently as a Ph.D. But I can tell you, as someone who's looking at this, I have many, many questions about this, right? I have questions about whether or not she'll be able to continue the treatment regimen that each one of these pills to be successful needs to have. I have questions about what kind of logic was put into the prescribing of them all and how they're going to interact with each other, and whether or not she'll even be able to fill them as we go on. And a final question for me is whether or not we might be better suited spending a little bit more on different kinds of aid, right? What if we had more income support, more stable income support? So as we think about today, I just want to make the connection between the lives of families who are most vulnerable to a crisis that affects us all, and also encourage us to ask the question of whether or not the opioid crisis is only the most deadly example of a broader set of phenomenon that we have to address. Thank you. And I'm going to pass it off to my colleague, Debra Furr-Holden.
Hi, I think I'm the only one here today from Michigan State. Am I on this mic or this mic? Whoa, I'm not alone. It's really great. We went out after the reception last night to the Gandhi Dancer, and I will tell you, being in Flint, I appreciate the hospitality and wonderfulness of my great friends and colleagues here at University of Michigan. I want to talk a little bit about some of the statewide efforts that we have that are happening at Michigan State. And then I'm just going to give you all a forewarning. I'm going to shake my finger at you and I'm going to shake my finger at myself, because the punchline, I want you to know where we're going, is we have to do better. We just have to do better at working together. I'm listening to a lot of what's being said about all of these great efforts and initiatives. And when I hear them all, I think, God, what if we actually had a way to connect all of those dots and create a web where all of those things could work in synergy? What if we were actually pushing the right levers? We would be maximizing the benefit of all of this work to the populations that we seek to serve. So that's where we're headed. So what do we have happening at Michigan State? Well, we're the land grant institution for the state, which is a new phenomenon for me, but it's a really important mission. You know, the land grant mission is that the innovations of the university, of the academy, live and reside, and that the community be the primary beneficiary of those. What's really cool about the work of extension is it is this massive built-in statewide infrastructure with boots on the ground for getting things done. We have more than 700 extension agents deployed all across the state, health educators, practitioners, healthcare workers, paraprofessionals, professional supports. We're in all of the counties in Michigan, and several of those have primary efforts around opioid prevention. We also have now a new project that was launched out of our Office of University Outreach and Engagement. Who here has ever heard of OPEN? My colleague who named this had not. This is not the OPEN that you know about. U of M created OPEN, an opioid prevention network, in 2016. Like, can you get when I say we gotta do better? Like, we gotta do better. So my colleague sends me this slide. I say, look, you know, I want to sort of say what we're doing and give people a chance to think about, you know, how can we bring some of these things together? And so she was out of town. And so I got the slide just a couple days ago. And I sent it, and Chad, who created the Open Network, was very gracious. And I could just see him shaking his head on the other end.
We'll take credit for all the work.
Yeah, right? So it's really interesting because it's sort of simple. You know, it's really great because one of the things that I love about living in the state of Michigan is there's a tremendous will from the people, right? So I do see people really attempting to come together. And this issue around silos, I don't think it's unique to MSU or U of M or Wayne State and just the universities. I mean, we sort of all are that way. There are people at MSU that are doing things that I could be partnering with that we just haven't figured out how to come together. So I'm not saying it's a bad thing. I'm just saying there's an opportunity before us. So this is a new space for our Office of University of Outreach and Engagement. MSU Extension is a partner in this. My division is a partner in this. You know, we applied for this grant to get, you know, people who are committed with the service model to working on the ground floor, supporting the efforts around opioid overdose prevention. And so it was a well-meaning and really smart idea. But I said, this is a new space for you. Why didn't you invite somebody from Wayne State and from University of Michigan and all of the other leading places who this is not a new space for them to participate in the board? And we actually had that conversation this morning. And you know what she said to me? Why didn't you say that to me 3 months ago? So we're saying it now. So we are going to do better. But the Open Network, so expecting them, it's like only more work, but it'll be good. But the Open Network is providing more human resource on the ground floor, people who are well trained. They will be embedded within 20 different communities in the community organizations across the state of Michigan. And it's funny because the slide is what it is, but that thing at the bottom where it shows who the partners are, that needs to expand. A lot of the partners are MSU, and a lot of those partners are people who are new in this space. And so, you know, I really think it's a real asset in what you've done and sort of bringing up to the surface what we're really doing in Michigan and what those opportunities look like. So I think that the call to action here is, number one, to increase the capacity of the local stakeholders to address the opioid crisis. You know, the work that we do with Extension and the work that is happening now with our Office of University Outreach and Engagement, it is not about us doing it to people or for people. You know, the reason that we are approaching it the way that we are is because our goal is to increase their capacity to meet their own needs. And we are in a unique position, I think, as academic centers and academic medicine and health centers to do that. The second thing is to identify what are those leverage points that we can use to build synergy across some of the existing efforts around prevention and intervention, and then as well as some of the future efforts and things that are coming down the pike. And then lastly, I think we have an opportunity to collaboratively address the gaps in our current opioid prevention efforts. Even if you took everything that we had and we figured out how to, sort of put it all together and make it all make sense, there would still be gaps. But I think we need to do that work collectively and efficiently. That's it. Thank you. And now I'm going to pass the mic over to my colleague.
Thank you. Well, as the last speaker of the last panel of a very full day, I have to say, looking out at all of you, I'm just amazed to see the room still so full. You've been all so good, so attentive, asked great questions. And I want to take a moment, and I hope my timekeeper will forgive me, to acknowledge as the co-chair today that it was my chair, our co-chair, Chad Brummett, who really made this day happen. We started out, I want a round of applause. Actually, we should all stand up. Come on, this was... Sorry, Chad. Okay. It was, just months ago that we got this assignment from our two presidents, and the president of Harvard gave it to a public health practitioner. I had just joined the faculty, and the president of the University of Michigan gave it to an anesthesiologist and a pain specialist. We were a little bit of an odd couple. But you would all know, because Chad described policy to practice in its highest form is art, that this is a very special anesthesiologist and pain specialist. It's been a real pleasure to meet him in person and to work with him. And everybody here, to me, who's worked for 30 years in public health, has talked like a public health practitioner. And that's really encouraging to me. And the fact is that a public health approach to the opioid crisis is not exactly rocket science. It may be hard to do, but it's not rocket science. And I like to think of it as an ADEPT response. The first strategy that we have to all unite around is that we have an obligation to keep people alive. That means naloxone needs to be in the hands of anyone who's around people who use drugs. That means that it's not only for frontline workers and first responders, but for people who use drugs and their family members. In New York City, most of the naloxone distributed is through syringe exchange programs, and the continued support of harm reduction strategies is really critical to keeping people alive. We've talked a lot about the need to follow the data, and I'll come back to that. And of course, we have to let people know what's available to them. Families need to know about what the options are for prevention, treatment, access to naloxone. And most importantly in my mind, and New York City began to do this when I was health commissioner, is using media to smash stigma, which we've mentioned a couple of times today, but remains such a burden on families, practitioners, and all of us who want to tackle the escalating toll of opioids. We've just finished talking about prescription painkillers. This opened the door to the opioid epidemic. The door is still open. It was opened with the enthusiastic facilitation of the pharmaceutical industry. And there are lots of things that we can do to address prescriptions. We can educate physicians. New York City took a page from the pharmaceutical industry and implemented public health detailing, going door to door. And then, of course, there's the prescription drug monitoring and the use of prescriptions to keep a handle on what's going on and hold practitioners, prescribers accountable. We need to have effective treatment everywhere. It's just absolutely unfathomable that the kind of estimate that's used today is that only 20% of people with substance use disorders are in treatment. And not all of them are even in effective treatment. They may be in treatment that is not effective. No one should ever have their treatment interrupted by incarceration. And happily, we seem to be on our way to that with legal judgments. When people talk about treatment, they often talk about detox and 28-day residential treatment. We need to make it very clear that effective treatment means medical treatment. Now, New York City used some of these strategies, and it bent the curve in many parts of the city. I want to take a moment to talk about something that I learned at Massachusetts did that I'd never heard of, and I don't know whether many people have. And this was under the leadership of Charlie Baker, Republican governor of Massachusetts. In 2015, signed into law Chapter 55, which allows government agencies to unite 10 different databases, named databases with individual identifiers, across 5 different agencies of state government. And they've been able to do some pretty incredible things with this database. They've been able to put a number on the risk of fatal overdose for people after they have been incarcerated, 130-fold higher. For homeless individuals, 30-fold higher. They've even been able to put together a group of people who got opioid prescribed for 3 months or more, follow them over time through these databases to figure out what the length of time was to an overdose. 36 months, it turns out. So I really think that Massachusetts has become a gold standard in how to use data across agencies, largely criminal justice, clinical service delivery, prescription, and public health data. And Massachusetts has really done incredibly. It's in a unique position among states in having reduced its overall overdose mortality rate and has bent the curve now for 2 years running. So I think we can say that Massachusetts is on the way down. New York City hasn't gotten there yet, citywide. But as usual in public health, we have gone far and still have far to go. Massachusetts is still in the top 10 in terms of overdose rates in the United States. It still has 2,000, actually closer to 2,100 people who died in 2017. And I think we should reflect on the fact that thinking about rates is not always the most complete way to think about the toll of opioid overdoses. When we look at numbers, Ohio, Pennsylvania, Florida are losing over 5,000 people a year. Michigan, which is not in the top 10, loses more people to overdoses than Massachusetts. This kind of thing happened in New York City, where in Staten Island, which is our least populous borough, we call our counties boroughs in New York City, and I'm still always forever a New Yorker, I still use we. But that was the highest rate, and the health department piled in, the whole community of Staten Island really piled in to say we have to change the risks of prescription overdoses and opioid overdoses overall, and we bent the curve. But even if New York City had been able to avert every single overdose death on Staten Island, the citywide rate would have gone down only by 10%. Over half of the overdose deaths in the city were occurring in Bronx and Brooklyn. So we had to pile in there too. I want to take, and I'm going to run a little over time, a minute or two, probably more like 2, to take a step back from talking about what we should be doing and how we should be doing, to asking ourselves, why are we here? How did we come to be in a place where it's still so controversial to talk about keeping people alive who use drugs, broadly known as harm reduction strategies? Why do we only have 3 drugs to treat opioid dependence? Imagine if we only had 3 drugs for hypertension, heart disease, diabetes. And why is there so much stigma and shame among people who use drugs? We heard about that from David earlier today. Among the families that love them, among the health workers whose job it is to look after them. We're in May. This is graduation month. Many families are going to be congratulating their children for graduating from college, from professional schools. They'll be saying, you know, I'm so proud of my daughter, the engineer. I'm so proud of my son, the doctor. We need to be in a place where parents can proudly stand and say, I'm so proud of my son. He's in recovery. So when we think about why it's not like that, I think we have to look to the past and ask ourselves who in the past was mostly affected with opioid dependence. The previous epidemic, heroin epidemic, largely affected people of color, Black and brown people. Black and brown people got the war on drugs. It was not greeted with compassion, sympathy, or empathy that we're seeing correctly now. It was not greeted with treatment. It was greeted with punishment. Handcuffs, not help. And when Massachusetts looked more closely at its data, you can see that the downtick that occurred in Massachusetts was not a downtick that occurred for everyone. The African American population, although with lower rates, is continuing to rise. And this is being seen across the country. And particularly hard hit are Black men, with continuing rise in overdose deaths. We haven't bent the curve in the Black population. And I'm terribly afraid that as the demographics of this epidemic shift, and that's what we see in public health, and when people learn how to prevent things, it's people with the resources and capacity who protect themselves the fastest. We need to keep our eye on maintaining compassion and care. We have already paid too high a price, all of us, regardless of how we identify, for the response that was based on punishment. So an ADEPT response is really not just a public health response, it is a just response. And I listed some things that I thought about doing as a health commissioner. I've run out of time. You know, we could get really bold and say we need to repeal the Harrison Act that kept doctors from being able to prescribe opioids for addiction, or that we need a Ryan White program for opioid dependence. But just to remind us that we need to keep a lens on the racialization of addiction, and we need to take action. Thanks very much.
Thank you, all of you, for those amazing comments. Building on Dr. Bassett, what you said, and also Dr. Furr-Holden, and you as well, Dr. Shaefer, in your local work, can you, all of you, talk a little bit about best practices for engaging community members? If you're in academics, if you're in public health departments, how do you really engage local communities in this work?
I can talk about what we do in Flint, and I think it's really important, and I have lots of colleagues I know here who are very actively engaged in Flint and have been a stake in the ground for that work. I think that probably the biggest mistake that we make with community is we already know what we want to do. We've got everything already figured out, and then we go and we try to sort of sprinkle them around after the fact and make it work. So I think the first thing is we have to value the voice and the role that the community plays in the process. Nobody wants anything done to them or for them. That's very paternalistic, and it doesn't work, and it can't be sustained. If people can't own it, it can't be sustained. And so I think if we value the voice of community and we include them at the outset, And then we have the humbleness and the humility to say, even though science and evidence and best practices say this, if we can't get uptake with the people that it matters with, it doesn't really matter. But it's hard when you've devoted your whole career to building a mountain of evidence. But we did that in the absence of the people that we were trying to serve. So I think we need to bring some humility to it as well, to try to have that meeting of the minds.
I agree with everything that Debra said, but as just reflecting on my time as health commissioner, it was really interesting when we went to Staten Island, which is sort of the blue-collar, white blue-collar, it has very diverse sections, but we got a lot of participation from the community that was outraged that they were losing their children to opioid overdoses. In the South Bronx, which never stopped being ravaged by heroin, people didn't want to talk about it. And I think that we need to understand that in public health we have to take responsibility for these ideas that also became embedded in communities, that the use of opioids reflected not just personal deficiencies, but failed families, communities that lacked the cultural resilience to resist addiction. Staten Island had never experienced that, but places like the South Bronx got it for decades.
Have become a big fan of community health workers and other methods that engage communities that we're seeking to serve, not just in advising in the work that we do, but doing the work itself. Community health workers have proven to be effective in treating many chronic diseases. What are the ways that we can expand that and actually recruit from the communities that we're seeking to work with to do the work, and in doing so also create meaningful job opportunities and career pathways?
Yes, and we also had a great opportunity to work together when I was in Detroit on the community health worker program, so that was great. One other question, and then I think after that we'll go to questions from the audience. What are some of the broader social policy changes that could really have an impact on this epidemic for all three of you?
So for me, they fall down into three buckets. I think employment and economic opportunity are an important piece of this. And we have a number of studies that are showing things like subsidized jobs program that can create meaningful employment opportunities, improve outcomes during those. And then I think there's a lot to explore with community health workers and other types of economic opportunities that can get people engaged in real work. The second piece, to me, from a prevention standpoint, can be said as show me the money. I think actually cash income support can be very effective. And in fact, we're getting a lot of studies that show, especially with families and kids, that across the population, when you increase income support, you decrease substance abuse, because often those things are a response to stress in the environment. And the single most effective thing you can do to relieve that stress is give people more flexibility to meet the needs as they see fit. And finally, at both a federal but also at a local level, we need to look at affordable housing. So I think there's a very strong linkage between what we're talking about today and homelessness, both as a cause and a consequence. And we need to do more to address the affordable housing crisis in this country. So the head of the Community Foundation in Marquette in the UP was just telling me that some of the folks at the church in their town decided to create a homeless shelter. And they have had the effect of being inundated from miles and miles away of folks who need a place to stay. So we need to look at more housing support, but also at a local level, can we break down exclusionary zoning laws, which have been sort of one of those social determinants that have led to segregation by race and income in this country, and make sure that people have a safe place to live.
Okay.
I really think that all of us who consider ourselves health workers need to start using some of this language too. We may not be able to do anything about directly about housing, but we can lend our voice to saying that when people don't have a decent place to live, that they don't have a foundation for a healthy life, or when they don't earn a living wage, So I know you describe yourself as a doctor who doesn't actually look after people, but I would beg to differ with that.
I think the only way that we can turn the tide on these social determinants is especially if folks in this room and a lot of rooms like it start to recognize these things as central to the work that we do, and making the case and not expecting it to only get discussed in other rooms.
I agree with that, but I feel like I would be remiss if we don't go back to the point that you make about the racialization of these problems. Because honestly, even the things you talk about, like housing and those things, Black and brown people are often excluded from that. So if you look at when these programs get implemented, oftentimes the people who have need aren't the beneficiaries of them for no other reason than they live in poverty or they're a person of color. Same way with the criminal justice system. The young man who spoke today, it was so moving. And I also, at the same time, couldn't help but have a reaction when he said his 5th time having, not been successful with parole and probation. I don't know any African-American person who's had 5 chances to stand before a judge having violated probation and then makes it to drug court. We live in a world where we've placed a hierarchy on the value of human life. And if we don't address that, we've really failed society.
I couldn't agree more.
Yeah.
Can I push a little bit more there? What if you're in the audience now, you're a policymaker, you work at a local public health department, what can they do tomorrow to try to address that?
I'm an epidemiologist by training. We do really great counting. I'm like a glorified counter. And I'm not kidding you. One of the biggest tools that we have, and it's simple, you saw it in Dr. Bassett's presentation, is stratification. If you look at the data and you look at a community, you might look at a mean or an average for a population, and there will actually be nobody in the population that'll fit the average. Half the people will be a 0, half the people will be a 1. But if you look at the average, everybody's a 0.5, right? So when she broke down the numbers, it said, oh, well, Massachusetts is going down. But when she disaggregated that by race, you could see that it was going down in all of the communities, except in the African American community, it was going up. So the first thing is, let's just be willing to look at the data. And then let's look at some of those social policies and social determinants underneath of that data that are giving rise to those inequities that we see in outcomes. Why should Black people be left out of the innovation and the progress being made in the opioid epidemic?
Yeah, thank you. My wish list would be that we had more people going straight to treatment and bypassing the criminal justice system altogether.
Yeah.
We really, have to accept that this is a chronic relapsing condition. Who would start depriving people of access to effective treatment and put them in a punitive context if their congestive heart failure relapsed or their diabetes went out of control? And yet, when people are on parole or probation and they have a relapse, they're suddenly thrown back into a totally punitive role. I would love to see that reassessed. And then, using the ADEPT, we really have so much more we could do to keep people alive. It begins with trying to put naloxone everywhere, including in the hands of people who use drugs. But it also means having safe spaces, accepting that our goal and our success is keeping people alive, and that safe consumption sites should be considered. I don't know anywhere in the United States that has yet implemented them, and I don't know anywhere in the world that has seen a fatal overdose in a safe consumption site. So, these places are safe. And I could keep going. We talked all day about data. Yeah. New York City committed to having quarterly data made available. I think any jurisdiction could commit to doing that. And so that could be a call to action. And this incredible linking up of data where somebody can be tracked from their prescription to the emergency department that they ended up with an overdose really allows an insight into what's going on with the epidemic. Massachusetts is really phenomenal in that. And, we talked earlier about prescribing, and we have Michael's still here. He might have to speak to this more, but the use of prescription databases for nudge interventions, he showed that telling people that you're prescribing more than 80% of your peers doesn't work that well. But what about also the people who are prescribing zero? Maybe they should be reminded that this is a part of our armamentarium. I would love to see us try those nudge interventions again. And acknowledging that door is still open. And until we close it, it's going to remain a way that people have a pathway to opioids. But most of all, the stigma treatment interface is really worrying to me. I don't know what we could do to make it clear to people that anyone can become addicted. And that everyone deserves to be supported in recovery, to try and make people feel less ashamed about that.
Thank you.
I wish we'd had the mother of David here. I don't know if David is still here, but she probably could have told us something important about that.
Thank you. Should we go to questions from the audience?
So community health workers play a pivotal role in connecting individuals with services. How can we better support this model to improve the health and well-being of communities, especially those with the largest gaps in access, such as rural communities?
Well, I think in Michigan, it's my understanding that a key element is finding a sustainable funding mechanism for CHWs. So CHWs in the state are funded primarily through philanthropy, and so they're never going to get past pilot models. So the project that I have been really excited to partner with Dr. Khaldun and the Department of Health, as well as CDCs in Detroit, in Cody Rouge, was to recruit folks from the Cody Rouge neighborhood, train them, equip them, and then at the community level bring CHWs out and try to hit a few community level markers of health. And I think we could apply this in a lot of different places. So I've been talking to Amy and Chad about the idea of could we do more? I think there's some of this, but how can we innovate with using CHWs in the rural settings to do prevention, education, as well as disposal, right? Safe disposal. And so I think these are all things that we could look to CHWs, but there has to be sustainable funding to make it work.
Correct.
We actually use a lot of community health workers in the Detroit Health Department. I want to really emphasize the fact that community health workers really need to be from the community and have a shared experience with those communities that we're trying to support. We actually in Detroit had a program again for pregnant mothers, and we had moms or people in our program who had been homeless, who had been parents who had troubles with housing insecurity. And so when we anecdotally spoke to some of our moms in the program, they would say, oh my gosh, I would never have gone to any of these programs. Like, I didn't want to go. My doctor tried to get me to come. I wasn't trying to hear it until your program and my community health worker was able to support me. So they are, and there's evidence that they're very effective, and we need to really look at those payment models.
Especially when they're linked to health service delivery. Right. Luke has hit on the real problem. This is something that bridges two important parts of my life. I lived for many years in Southern Africa, as you heard, and community health workers in developing countries are widespread and widely accepted. And it's great to see us learning from the rest of the world here in one of the richest countries, but they have to be paid. They can't be volunteers. It just does. They have to be treated as workers. So somebody has to pay for them.
We look at the opioid public health challenge. Could the panel comment on the unique challenges faced by the justice-involved population and any innovative practices for this population that are in place?
I don't know that we're the right panel they're probably our colleagues from criminal justice who spoke earlier, but they're the drug courts, which people consider innovative. That's what allowed David to. Do you want to speak?
I can say, just speaking from my experience in Baltimore and Detroit, there's a lot of issues with people not having access to treatment once they're in the jail system. We know there's a lot of churning, so oftentimes people in jail, they go out and they come back. It's hard for them to get connected to just general medical care and social services, let alone treatment, MAT. So we really need to be looking at continuing treatment. Someone earlier today talked about you shouldn't have to stop your treatment because you go into jail. But there are many challenges that we can address, including drug courts and diversion programs for law enforcement.
I think there's been a federal court decision. I mean, the sort of legal defense of continued treatment while people are incarcerated is growing. But people really, New York City's has had a methadone treatment program in its jails for years, but it had limitations. And we heard earlier about they weren't using buprenorphine very much. So this is a problem that really has to be solved because of these incredible risks to people when they leave a prison or jail of a fatal overdose.
I would just add that I think in this particular space that this is it's important to return to Debra's incredibly important point about the racial equity implications of these policies, and making sure that the pathways we go down to address the wrongs of over-incarceration, both in this field and more broadly, that those paths are racially equitable. Certainly, the run-up hasn't been, and so there's been disparate impact in very serious ways.
When you were speaking about the number of people that are in recovery programs and that not all recovery programs are effective recovery programs, the Health Professional Recovery Program, HPRP, seems to have pretty good results, somewhere around 70% effective. Why aren't treatment centers modeled more after these programs?
It's so funny. I'll just say something basic. The question you asked earlier, we call this all the F word. It's all linked to funding in large part. We've just launched a peer recovery corps in Flint, and many of the services that are needed there's no way to pay for them. So we've got peer recovery coaches and peer recovery advocates who are providing services, and there's nowhere to bill, there's no way to get reimbursed for those services. And I actually think it's just such a undermining malignment of what we try to do with community health workers when we create this volunteer workforce out of people who are on the front lines in recovery. I think it's very unfair. I think it's very dishonoring of them and the role that they play. But I think a big part of it is we need to have sustainable funding models for things that we know that work, and we simply don't have that right now.
Sure. So if everyone could just give a final thought. I've been told it's time to wrap it up.
That's mine. You go, then you go.
Well, I just want to come back to the importance of acknowledging that we have to tackle stigma, that much of the stigma associated with opioid use disorders is related to the racialization of addiction from the heroin epidemic of the 1970s. I would implore everyone to be vigilant. We don't want to lose ground on the idea that we need to help people and not punish them, even as we are seeing a shift in the demographics of opioid use and particularly fatal overdoses.
Yeah, this is a public health problem. It's not a criminal justice problem. It's a public health problem. And I think we have the tools and we have the knowledge. I think we lack some of the infrastructure and we lack some of the resources. But I mean, if you look at the power in this room, we've got they said the Michigan of the East in the room. We've got University of Michigan and Michigan of the East. So if you know, and the notion that it's somehow miraculously going to come from out there, I request that we all forfeit our right to think that way. The change is going to come from us. The advocacy is going to come from us. I was not trained as a researcher activist, but to do the kind of work that we do, you have no choice but to sort of take it on if you want to see change. So I feel like I'm grateful and honored to be with this group, and I think this public health approach is exactly the approach we should be taking.
Yeah. I guess I would just end by saying I think it's great to have so many different perspectives in this room and to be tackling it in that way. When I first got invited to speak, I thought maybe they had the wrong person, but I think we all can have conversations across boundaries, and as focused in on a lot of our solutions have to be, I would just encourage us all not to lose sight of the broader context in which all of these challenges are embedded.
Well, thank you. Thank you for a wonderful panel.
Do you know my favorite lady?
Thank you very much. That was a terrific panel and really appreciative. And Luke, it was not the wrong email address. I knew exactly which email I was writing, and you brought such important context today. As we wrap up, I will remind everyone, well, I need the slide up here if I could, please. Yeah, thanks. So this is the upcoming part 2 of our Home and Home series with Harvard. This is not football. I think that was discussed among the presidents as well. But we're going to do Home and Home. So October 10th, we will be having our second summit. And this will be really, I think, as Mary and I talked when we first came together, we really focused this more on policy and prescribing, and the fall conference will really focus on addiction, access to treatment, and stigma. And we have a terrific list of speakers for that event that's still being formed, but that should be a terrific. So put it on your list, and hopefully we will be able to webcast it for those that are unable to travel out, but certainly consider coming out and seeing us. I want to just remind everybody of our sponsors today, which should be here. We had an incredible outpouring of support from all of our different funding organizations, and Blue Cross Blue Shield of Michigan, the Value Partnerships, the SAMHSA grant, the SOR grant from Michigan Open, Injury Prevention Center, MISHR, and University of Michigan Precision Health. And then I am going to ask, so all of the IHPI and Michigan Open staff that contributed today, can you please stand for me, Trish and others? Can you guys please stand for me? Can I get a round of applause? You got to stand up. You actually have to stand up. There's a few in the back over there. Oh, our tweeter-in-chief in the back. So, it is, I have been getting a lot of compliments for putting together a great event, and I hate to come clean here. But the people that put together the great event are the people that just stood up to, and I have been blown away by the support from IHPI and then my own staff at Michigan Open. They have really brought this all together, and it is, we weren't sure how many people would show up when we first started. We thought maybe we could do with a room of 200. We had 440 registered and about a wait list of about another 80 people that were unable, and we even were able to pull off of our wait list. And I think at last count we had more than 500 people registered for the webcast. Not sure, we'll find out how many logged in, so thank you for that. Thank you for spending your time with us today. I hope you understand that this is just the beginning of a conversation, and what I really hope, and as Mary and I first started talking, this is about community. And this is, as Debra said, we can't have lines. I jokingly put out a go green on my Twitter just a minute ago, because Michigan State, Wayne State, community health, we all have to be in this together. We have private and public payers. And we also have policymakers. And as policies are being made and as new practices are being implemented through our payers, I guess I just want to put it out there that we have a wealth of expertise at this university, at universities around our state, and people who are ready to share and collaborate to make our state healthier. And we really have to work together. And I want to, again, recognize Ms. Groen from the governor's office for coming here today and being part of this day with us. Thank you for that. With that, I want to congratulate you on hanging through till the end, and tell you how appreciative that I am for your support today, and want to just thank you. I Appreciate it. Have a great day.